Your hammer on a broken bell. Broken bell, a broken bell. Don't waste your hammer on a broken bell. Shadows rise when you hear the call. Shine the light and you watch them fall. Watch them fall with the coming day. Shine the light and they fade away. Well, I let you in, see inside. You will never change my mind. You will never change my mind. Cut your lies with a rusty tongue. Build your house with the deed you've done. The deed you done got a ringing sound. The deed you done gonna tear you down. Well, I let you in, see inside. But you will never change my mind. You will never change my mind. Copper and tin for a shiny skin. Shiny skin, shimmering new. Copper and tin, the ringing true. Tolling laws crack my shell. Don't waste your hammer on a broken bell. Broken bell, a broken bell. Don't waste your hammer on a broken bell. Well, I let you in, see inside. But you will never change my mind. Never change my mind. You will never change my mind. Never change my mind. Tall grass whispers, the hills when the wind blows. You stand dreaming deep in the willows. Two boys tumbling, chasing your shadow. Smiling, lost in the echoes. Follow me through tall grass. We walk for hours. Hide me on this hillside. Maybe we won't make our way back home. Tall grass calls, but I am here alone. The hills have vanished, blackbird is silent, the sea is stumbling. Two boys whisper, father's dying. tall grass withers, the willows are crying. Follow me through tall grass, we could walk for hours. Hide me on this hillside, maybe we won't make our way back home. The tall grass calls, but I am here alone. Follow me through tall grass, we could walk for hours. Hide me on this hillside, maybe we won't make our way back home. Maybe we won't make our way back home. Tall grass calls, but I am here alone. Chasing the days like a lost child, got no time left to play. I wander through the wild, eyes bright and wide, teeth and tongue. Love and I come tangled in a shining little sun. Hold to your light, don't ever lose your star. Oh, love, your light is a road to what you are. Both hands in the sky, 2 feet from the ground. One big happy heart for the whole world round. Walk to your light, don't ever lose your star. Oh, love, your light is a road to what you are.
And welcome to OMSI's Virtual Science Pub. My name is Miguel Rodriguez, and I'm the Talent Development and Inclusion Strategist here at OMSI. I will be your host tonight. I'm actually very excited to learn more about Oregon's response to COVID-19 and be here with all of you in community. OMSI is committed to sparking curiosity and igniting imaginations. To help everyone out at home, we've crafted and curated all sorts of engaging activities and experiments to inspire you to experience the wonder of science from wherever you are. Visit omsi.edu for more information and resources. And if you do any of these science activities, please send us some photos or videos so that we can see how great of a scientist you are, but also to have some awesome images to reflect back on. I also hope that you enjoyed tonight's pre-pub trivia and music with Tony Furtado. We are excited to not only just showcase local Portland musicians at our virtual events, but learn some fun facts along the way. Putting on these live shows takes a lot of work, and we have an amazing partner that helps us make this happen. A big thanks and shout out to Celestream for providing the live streaming services for tonight's Science Pub. We really appreciate their support. We're excited as well to welcome you back to the museum to experience body worlds and the cycle of life, and tour the USS Blueback submarine. Advance tickets are required. The health and safety of OMSI guests and staff is of our utmost priority, and we want you to feel comfortable and safe while at OMSI. To meet state guidelines and help limit the spread of COVID-19, OMSI has implemented some changes throughout the museum. Visit omsi.edu for more information. And guess what? There's something else you can do to support your local community. We have some outstanding food and beverage partners, and I would encourage you to put the pub back into the Science Pub experience. So go ahead and order some delicious food and tasty beverages from one of our partners from around the state. Tonight's event will be very similar to our regular Science Pub program. And for those of you that don't know what a regular Science Pub looks like, we are going to begin with a COVID-19 themed trivia game that is a warm-up for tonight's talk. So please grab a pen and paper so that you can participate. And after that, we'll have a lecture by Dr. Bangsberg. For the Q&A, you can submit your questions at any point during the lecture via the comments on our live feed, and we will collect them all. And after the lecture, I will ask your questions to our speaker. If you enjoyed tonight's lecture, please consider making a donation or purchasing a Science Pub pint glass. The link is in the comments section. And don't worry, there's no pressure to donate. Our mission at OMSI is to inspire curiosity by creating engaging science learning experiences for people of all ages and backgrounds. So sit back, relax, and get ready for a great lecture. All right. This week, we have our Director of Guest Engagement joining us to play along live with you at home. So please give a warm welcome to Andrew Haight.
Hello, everybody.
Welcome, Andrew. It's good to see you. What are you most excited to learn about during tonight's show?
Well, I'm really excited to hear Dr. Bangsberg's perspective on how the state is responding and the pace at which we're responding, how quickly we're able to respond to some of the issues that we're seeing with COVID-19. I think I'm really interested to learn about how quickly and how we're comparing to other places and the pace in which we're going.
Okay, awesome. Likewise, not just you, me too. So, all right, so let's get started with our trivia game. So once again, grab a pen or pencil and paper so you can play. Perfect, Andrew's got it. So you can play against your family, or you can just, if you're all hanging out by yourself. I suggest you make it a little interesting. So if you have roommates or family members, maybe you play for bragging rights. You could also play for who's doing the dishes next, who's taking out the trash, maybe washing the car or something. Just make it fun. So there are 10 multiple choice questions. I'll read out a question, give you time to guess, and then I'll reveal the answer before moving on to the next one. Are you ready, Andrew?
Let's do it.
All right, let's go ahead and get the first question started. All right, so question number 1, what is a virus? So the options are a microscopic single-celled organism, a submicroscopic infectious agent that replicates only inside the living cells of an organism, or the last one, a multicellular organism with chlorophyll as its primary photosynthetic pigment. What are your thoughts, Andrew?
Yeah. So C is a plant material, right? So I can eliminate that one.
Process of elimination.
That's right. I think A is pretty much everything. We're all made up of single cell organisms. So by that, I'm going to go B, a submicroscopic infectious agent that replicates only inside living cells of an organism. Yeah, that one.
Final answer, phone a friend?
Yeah.
All right. Yes, correct. The answer is B, a submicroscopic infectious agent that replicates only inside the living cells of an organism. All right, 1 out of 10, Andrew. You better get at least 90%, 9 out of 10. High expectations. All right, we're going to the next question. Question number 2, why is it called COVID-19? So is it A, there are 19 molecules that the virus is made up of? B, it was first identified in 2019? Or C, it is the 19th identified coronavirus since the WHO began naming them?
Yeah, this is good. I was confused by this for a long time until a couple months ago. I had a conversation with one of Dr. Bangsberg's colleagues about this. And yeah, I'm gonna say again B, that it was first identified in 2019. Yeah, that's what I'm gonna go with.
All right, let's see. Yes, you're on a roll. All right, so yes, it was first identified in 2019. All right, you ready for the next one, Andrew?
Yeah.
Right.
Good. I'm feeling momentum here.
Yeah. All right, number 3. What is the more effective method of removing the coronavirus from hands? So is it A, washing hands with soap and warm water for 20 seconds? B, alcohol-based hand sanitizer? Or C, fire? That typo? No.
For the health and safety of everyone's hands at home, I'm going to eliminate C, I think. I don't think it's C. I don't think it's going to be fire. Yeah, washing hands is an interesting one. Like, when you wash hands for 20 seconds, you're mechanically removing germs and bacteria from your hands. Like, the soap is, like, separating those things from your hands. I would assume alcohol-based hand sanitizer isn't necessarily doing that because the soap is what removes it, and then it's the soap and then it's the water that pushes it away. But then the alcohol-based hand sanitizer, I think, kills the virus. So what's more effective at removing the virus? I'm going to go with A, because I think A is more effective at removing the virus from my hands.
Yeah, I personally thought it was B. So let's see what it is. Yeah, more effective. So it's definitely A, washing hands with soap and warm water for 20 seconds. All right, so I would be 2 out of 3. You're definitely 3 out of 3. All right, I can still come back on the come up. All right, let's go to the next question now. Number 4, this is not the first widespread coronavirus that humans have encountered. Which of these is not a type of coronavirus? So A, severe acute respiratory syndrome, SARS. B, Ebola. C, Middle East respiratory syndrome, MERS.
Ooh. Which one of these is not a type of coronavirus? I'm pretty sure B, Ebola, and not because I'm confident in I know what Ebola is, because I actually I'm not familiar with Ebola, but I'm pretty sure that the respiratory system and that effect is what has it in the coronavirus kind of category. So I'm going to go with B as not a coronavirus.
All right, I like the deductive reasoning there. All right, let's see. Yeah, so the right answer is B, you're on a roll. So yes, Ebola is not caused by a type of coronavirus. All right, SARS is a pneumonia-like coronavirus that first emerged in 2002. And then MERS developed in 2012. So yeah, all right, awesome. You ready for the next one, Andrew?
Yeah, let's go.
All right. All right, question 5. Which organ does coronavirus primarily attack in the body? A, the heart. B, the brain. C, the lungs.
Yeah, this one I feel like following the news, hearing about respirators and things like that, I'm going to go with C, the lungs is the primary effect.
Okay. I think also from the previous question.
Yeah, good point. Yeah.
All right, so C, lungs. Let's check it out. All right, yeah, you're on a roll. So the infection comes in via the airways and spreads to the lungs. The more dangerous symptoms are caused when dead cells and antibodies flood the lungs with fluid and debris while trying to fight off the virus. So for those of you that are watching, there's a typo in there. We're talking about cells, not L's. So, all right. All right, you ready for the next question, Andrew?
Yeah.
Awesome. All right, question 6. Over the summer of 2020, what item has doubled its sales from last year? A, kiddie pools, B, Himalayan salt lamps, or C, fidget spinners?
This is interesting. As the parent of 5-year-old twins, I have seen in my circles a massive uptick in kiddie pools for sure. But that B with the Himalayan salt lamps, I'm not entirely convinced of the science there, so I'm hoping maybe it's not that personally. Fidget spinners, I feel like they've been remarkably popular for a long time. I'm going to go A. I'm going to think the summer of 2020, we've seen a huge uptick in kiddie pools.
All right, let's go with A, kiddie pools. Yeah, awesome. All right, so what are you, 6 out of 6? I'm still at 5 out of 6. You're on a roll. Okay, we're almost in the final stretch. We passed the hump. All right, so kiddie pools, yes, and social distancing guidelines have gone into effect. So, all right. Let's go to question number 7. Can you give your dog COVID-19 for all those puppers? A, yes. B, no. C, only cats can get the virus.
Yeah. I do not know the answer to this. I do remember a story back in the beginning of all of this of a tiger at the Bronx Zoo getting COVID-19, or testing positive at least for it. And I think there was another example of like a lion at another zoo. So, I don't know about dogs though. I'm gonna go C. Only cats. Only cat.
Final answer, C, only cats? All right.
Oh!
Correct. All right, that's a tricky one though, for sure. So yes, so according to the CDC, a small number of pets worldwide, including dogs and cats, have been reported to be infected with the coronavirus, COVID-19, mostly after contact with people with COVID-19. So that's unfortunate for our pets, but yeah, it appears that the virus that causes COVID-19 can spread from people to animals in some situations. So yeah, I heard those stories too. Yeah. All right, you ready for the next one? All right, the streak is over though, Andrew. All right, question number 8. Are people living with HIV always more at risk of getting COVID-19? A, yes, people with HIV have weaker immune systems. B, no, people who adhere to antiretroviral treatment, ART, and have a high CD4 count are not more at risk.
Wow. My instinct is to say yes, because of the way, people with HIV have weaker immune systems, are more susceptible. I don't know what antiretroviral treatment really means, or a high CD4 count really means. Like, is that what we all have typically? I don't know. I'm going to say yes. I'm going to go A.
Okay. All right. Let's see.
No.
Okay. And I didn't know this one either. So let's see. Medical experts agree that people on antiretroviral treatment who have an undetectable HIV viral load and a near normal CD4 count do not appear to be at a higher risk than their HIV negative counterparts. So, yeah. That's something maybe we need to do a little bit more research on, but yeah, okay. All right, you ready for the next question?
Yeah, I'll be curious to hear Dr. Bangsberg touch on that, because I know he did a lot of research in HIV and the AIDS community. So
yeah. All right, well, hopefully he addresses it when he comes up. All right. Question number 9. Which is most widespread? A pandemic, B, an outbreak, C, an epidemic?
I think an outbreak is when it's contained, right? Like, by definition, I think that's contained. And an epidemic, I think, has something to do more with like the length of time that it lasts. I don't know about that actually. I think something that's more widespread is a pandemic.
Okay.
Yeah, I'm gonna go A.
Below there. All right, let's check it out. Yeah, a pandemic. All right, so a pandemic is a disease outbreak that spreads across countries or continents. It affects more people than either an outbreak or an epidemic. The WHO declared COVID-19 to be a pandemic when it became clear that the illness was severe and that it was spreading quickly over a wide area. So, all right. COVID-19. All right, you ready for the last question?
Do it.
Wait, what's your score so far?
I think I'm 7 out of 9. I missed 2.
7 out of 9. All right, you failed my standards, but just kidding. Sorry,
Yeah, I know you're saying
All right, let's get the last question, Andrew. So question 10, a disease that can be transmitted from animals to humans is A, zoonotic, B, hypnotic or hypnotic, or C, stenotic?
Well, I'm going to eliminate B because I don't think it's hypnotic. I think that's a whole other. Stenotic, I don't know what that means. But zoo, in terms of like, you know, is often preface for some sort of animal zoological type thing. So I'm going to go A, zoonotic.
All right. Final answer?
Do it.
Dial a friend? No, I'm kidding. All right, let's see. All right, zoonotic, you're right, zoonotic. So zoonotic diseases, also known as zoonoses, are caused by germs that spread between animals and people. All right.
Here you go.
I learned something new today too. All right, what was your score, Andrew?
8 out of 10.
All right, be average, be average.
Yeah, I'll take it. I'll take it.
Awesome. Thanks for joining us tonight, Andrew, and thanks for playing along. I hope you had as much fun as I did. So.
Yeah, that's great. Thanks.
All right. Of course. And I hope all of you at home had fun as well, learning something new about COVID-19. So awesome. All right. Okay. So, and now I would like to introduce our speaker, David Bangsberg, MD, M.P.H, founding dean of the OHSU-PSU School of Public Health, is a Portland native. After graduating from Lincoln High School class of 1981 in Portland, he went to Johns Hopkins Medical School in Baltimore, followed by residency at Columbia Presbyterian Hospital in New York City and fellowship at UCSF. He was a professor at Harvard and visiting professorship in Mbarara University in rural Uganda and Vellore Institute of Technology in India, caring for people suffering from HIV/AIDS, addiction and homelessness. He learned the extent to which you are born and the social climate around you determines your health. For Dr. Bangsberg, returning to Portland to lead the new OHSU School of Public Health is making good on his commitment to change that paradigm. Currently, he is leading the Key to Oregon initiative to help reopen Oregon. At this point, Dr. Bangsberg, go ahead, take it away.
Thank you, Miguel. Really appreciate the warm introduction. And I want to thank you all for joining us tonight on Inside Public Health, perspectives of our new normal with respect to COVID-19. I want to thank all of you for being students of public health by joining us this evening to learn how we got here and how we responded in Oregon and where we go from here with respect to COVID-19. And I promise you, your first class in public health is free. But I also want to congratulate you that you're not just students of public health by being with us today. You are also practitioners of public health by helping us all slow the COVID-19 epidemic. Everyone has given up something. Everyone is missing being with our family, our friends. Many also have concerns about your kids missing school and maybe worried about your employment or your business or your job prospects. Many of you probably don't like wearing a mask. but please do wear them. They will save a life. Some of you have given up so much more. Some of you may have given up jobs, worried about your housing, don't have enough food. Maybe some of you lost a loved one. The people hit hardest have been Black, Latinx, Native Americans, and Asian Pacific Islanders. COVID has amplified and magnified the health disparities and inequities that have been present for decades, if not centuries. This also occurs at a time when we're facing 400 years of violence of racism in the profound ways with the murders of George Floyd, Ahmaud Arbery, Breonna Taylor, and Jason Washington on our very own PSU campus. Communities throughout the nation are getting into good trouble, as John Lewis said, protesting this violence, and many are being met with further violence. I am a cis, white, heterosexual male of enormous privilege. Privilege conferred on me by structural racism. Many have suffered and fought against racism, like John Lewis, long before I began to fully appreciate how and why racism has been and still is the most important public health crisis of modern human history. We can't talk about COVID-19 without also talking about structural racism. Because racism is the most important issue before COVID and will be the most important issue after COVID. And because the way COVID has magnified racist inequities that have been created over decades, not centuries, we must pay attention to this now, both now. Because Black, brown, and indigenous people are more likely to get COVID because of how and where they work, more likely to suffer the economic consequences of our interventions, including job loss, housing loss, food insecurity, and more likely to receive optimal medical care when they get sick, and more likely to die. It will take us years to respond to this virus, but it will take us a decade to respond to the social economic consequences of COVID-19, and we must start now to attend to this perfect storm of COVID amplification of structural racism. This is the most important time for public health, not in just my lifetime, but in our century. We must do more now. It impacts everyone, and impacts everyone to different degrees. And unlike HIV, it impacts everyone. And all of us need to respond. As I mentioned with respect to COVID-19, you are giving up things you enjoy to protect yourselves. You're doing this to protect the health of your family. And you're also doing this to make sure you protect your community, to limit transmission and illness, such health systems are not overwhelmed. And you're doing this to help our community, our state, our nation, and even the planet. We are responding to this in ways never before. By community mobilization, changing in funding, policies. It's part of every public health decision. We're responding well, and I believe the future is bright. And the future is bright because this is the first time that everyone, in one way or the other, is now involved. And oh my gosh, this is happening so fast. The reason this is happening is how fast the speed of this is happening is really part of my optimism. The first pandemic I was involved with when I was in medical school in the 1980s, there was this new disease called HIV/AIDS. We now know that the very first known case of a person infected with HIV/AIDS was in 1959 in Kinshasa. It took over 2 decades for HIV to become a pandemic. It only took just over 2 months for COVID-19 to become a pandemic. 2 decades for HIV/AIDS, 2 months for COVID-19. That's how fast this is happening. Why is this so contagious? HIV wasn't as contagious. One thing that HIV was not contagious, but one of the reasons it made its way to a pandemic is many people were asymptomatic and were able to transmit an HIV infection before they knew they had the infection, before they knew they were likely to become ill. The same is true with COVID. We now know that over half of the infections that occur from COVID are occurring from people without any symptoms whatsoever. The other global epidemic that I dealt with was Ebola. Ebola is also very contagious, but everybody with Ebola gets really, really sick. And it's really easy to know who to isolate, because as soon as you become sick, whether you get Ebola, you get sick, and you get sick as when you become infectious. So you don't have that asymptomatic period that is spreading the disease around the planet so quickly. The other reasons it's so happening so fast and so contagious is it happens through aerosol. It happens through our air we breathe, when we laugh, when we talk. The COVID-19 is literally in our air. That's why transmission is so much worse inside than outside, because we're in the same air, breathing the same air with this COVID-19. And that's why masks are so important and so effective at limiting transmission from one person to the other, both inside and out. But because it's going so fast, we are responding. We can get it under control. We have gotten it under control. We've made a few steps backwards, but this, we know what to do. And we'll talk about tonight. What can we do to get this under control? And Oregon has done a really, really good job. And more on that later. But doing things, giving up things to help yourself, to protect your family, to protect your neighbors, your community, your city, your state, giving up things for the common good. That's what public health is all about. And that's what makes you a public health practitioner. And thank you so much. We are all so grateful for what you are doing here in Oregon to limit COVID-19 transmission. So let's take a minute and talk about where we are and where we've been and how we've responded to get where we are. In the world today, there are 18 million infections, and to date, just under 700,000 deaths. The United States of America, we have 4.6 million infections and 154,000 deaths. We are the lead here in terms of infections and death worldwide. In Oregon, we've had 18,000 infections and 322 deaths. And I'll put that in perspective. Actually, Oregon has done very well. What did we do here in Oregon? Well, we had our first death related to COVID on March 19th. It took the governor and the Oregon Health Authority 9 days to close the schools, to close the businesses, and to issue the stay-at-home order, to decrease the interactions we have, to limit transmission. 9 days. How is that? How does that compare? Well, it took China, which did a very good job with COVID-19, 12 days to do the same interventions. And it took Washington, our neighbor to the north, a full 23 days. So Washington, 23 days, China, 12 days, Oregon, 9 days. It wasn't that we responded earlier in calendar time. COVID-19 hit China first and hit Washington before us. But we were able to recognize it and respond earlier in the course of the epidemic. So we could implement the interventions to limit transmission earlier in the course of the epidemic to bend the curve and have a greater response. We started to see the bend of this curve, the slowing of transmissions in the second week after the first death. We were worried, like New York City was, we would have an experience like New York City where hospitals and intensive care units would be overwhelmed. At the peak in Oregon, we only used 15-20% of our ICU beds and have been down to 10% for most of April. It's come up a bit since then, but we've not nearly use the ICU beds that we need, such that everybody can get the best and best possible care who gets ill or becomes infected and becomes ill with COVID. Then in March and April, we saw more benefits. We saw a declining hospital census, declining ER visits. And throughout March, we had the 4th lowest COVID infection rate of all the states in the country and the 8th lowest COVID mortality of any state in the country. It was because of this early response, this 9-day response, this complete response where everything was closed down, schools, businesses, that we were able to bend the curve, keep our hospitals relatively empty so everybody can get the best care possible. And we were able to donate 150 ventilators to New York City when they were needed most. And that makes me really proud to be an Oregonian. And we've done a great job. We did a great job, and we should be proud. We bent the curve, brought this under control. Then on May 14th, the governor, when things were under control, infections were all down, hospital visits were down, ER visits were down, infections were down. The governor opened up 28 counties on May 14th, and the remaining counties on June 1st, except for Multnomah County, which is a little bit slower. It was a bigger county, more populous, took a little longer to control transmission in Multnomah County, and Multnomah County was opened up on June 19th. Since then, since we've opened up the economy a bit, we've seen a 4 to 5-fold increase in infections. We've gone from 75 new cases a day to now just short of 400 a day. We've also seen a 4-fold increase in death, from about 1 death a day to now about 4 deaths a day. With this increase in infections, increase in cases, the state has ratcheted things down a bit and issued a statewide mask order with the appreciation of how important masks are at controlling the infection, and hope that we could keep the infection down with an open, more modestly open economy, but control it with masks, and also control it with another strategy, which called testing and contact tracing, such that we can find small pockets of infection early and have those people with early infection isolated at home to prevent transmission, to see who they are exposed to identify new infections, and keep them at home to limit pockets of infection before they become a full second wave. And the governor has also reduced gatherings from 50 people now down to 10 people. So as we opened things up, things got busier, we saw more infections, and now we started to gently tap things down. And so let's take a look at this, and let's see some data, some scientific data to see how COVID-19 infection has changed over time with these interventions in March, April, May, June, July, and over the summer. So may I see the first slide, please? Next slide, please. Great. All right. So here is the COVID-19 cases in Oregon from March, early March, through May, June, July. So you can see in early March, we had the first, mid-March is when the first cases were identified. The interventions were implemented near the end of March. It takes, once these policies like the stay-at-home order and closing businesses and closing schools, once those are done, it takes about 6 weeks for those policy changes, those changes in behavior to change the infection rate. So you can see about 6 weeks later, we see a peak in end of April, and May it starts to go down. And then a small peak, and it goes down even more. So end of May, beginning of June, we're seeing all of our curves, our new cases are going down. That's a really good sign. That is a direct effect of closing the schools, closing businesses, and stay at home. And then, as I mentioned, we started to open up some of the counties. We started to have more gatherings, have some business. And what you see is this coming up. Now the question is, and it comes up from 50 cases a day to now about just 350 cases a day. That's a lot. Some would ask a question. So, well, we're doing more testing. Are we seeing more cases just because we have more tests out there and we are diagnosing more people because we look for more? That has been raised. So let's look into that. Let's see, what is the evidence to support how testing will change number of people getting sick, number of people in the hospital. Is there really more disease? Next slide, please. Well, what are the best ways to know whether an increase in testing is leading to more cases, or whether it's an increase in new cases or increase in transmission leading to more cases? Is to look at this here, which is the percent of COVID-19 tests that are positive. So this is day by day, looking at the percent of all COVID-19 tests done in Oregon and what proportion are positive. The number of tests are going up dramatically. The number of tests have gone up several-fold. And as we look through March and April, we're seeing a positivity rate of about 6-7%. And then it comes down to about 3-4% in the May, beginning of June. We're doing more tests, but we're seeing less infections. This declining percent of people who are positive is because there's less transmission going on. And then as we start to open up the economy a bit and businesses restart, there's more interaction amongst people, the percent of positive people is going up. The number of tests are going up and the percent of those tests that are positive are also going up. This is a sign that there is indeed more transmission. Just modest more transmission, a modest increase in transmission, but there is more transmission because we're seeing the percent go up. And now we're about 6.5% of all COVID tests in Oregon last week were positive. Next slide. The other way to determine whether we're seeing more COVID-19 is whether we're seeing more disease. And there's 3 ways we can look at disease. We can look at who's coming to the emergency room, who's coming to the hospital, and who's getting sick and who's dying. So this is the percent of all emergency room visits that are related to a COVID-19-like illness. And as we see, when we first started seeing COVID in early March, there were the number of COVID-like illnesses coming to the hospital went from 2% up to 6%. There was more transmission. As we implemented our interventions, as we controlled transmission, the number of people coming to an emergency room with a symptom that sounds like COVID-19 actually went down. So this is reassuring news that there was a blip in illness coming to the emergency room, and it stayed below this 1.5% threshold that we look at. And so the emergency rooms are not being overwhelmed. If you were to look at many other states, you would see a very different curve. Next slide. The other thing we can do to look at this is look at the number of hospitalizations related to COVID. So these are people with the diagnosis of COVID who are sick enough to require going to a hospital. And as we saw, the first cases were identified in March. There was a really big increase in up to 12, from just a couple hospitalizations a day to 20 hospitalizations per day. As we close the schools, we close businesses, we had the stay-at-home order, fewer and fewer people got COVID-19, fewer and fewer people got sick, fewer and fewer people went to the hospital. And as these interventions, again, they take about 6 weeks before we really see the effect of these interventions. There's a lag. We are seeing a decline in hospitalizations down to 4 or 5 per day in Oregon, a very manageable amount. Now, as we opened up the counties and the economy starts going again and we see more transmission, and indeed, the number of hospitalizations are going up. Whether they will keep going up or whether they're going to plateau, I think it's too early to say. This looks like this sort of orange area here is very recent data. We don't have enough data to know, to have a lot of certainty around the most recent 2 weeks. So it's too soon to know whether this is starting to plateau or maybe hopefully it's going down a bit. It's just too soon to know. But as we apply our social or physical distancing interventions, we see COVID hospitalizations go down. As we loosen them up, they start to go up. Next slide. Now here's the most concerning data. Most people with COVID-19 get over their illness and do fine, but some people get very sick and can die. This is now approaching one of the leading causes of death in the US. We see the same, very similar pattern we've seen with hospitalizations. When COVID-19 first entered Oregon, there was just a few deaths per day, about 1 death per day. As transmission picked up, we saw 3 or 4 deaths per day. As we controlled transmission, through 6 weeks after controlling transmission, we start to see a decline in transmission, decline in hospitalization, and a decline in death. Then as we open things back up, we see a modest increase for June and July. More recently, we've seen a little bit more increase. This is something we need to keep a very close eye on, that we have seen an increase in deaths. It's not overwhelming our hospitals. Everybody is able to get the best possible care. We still have lots of hospital capacity in Oregon, but this suggests that there is indeed more COVID-19 being transmitted. More people are going to hospital, and sadly, more people are dying than during the peak of our interventions. Next slide. So this is another marker, and this suggests we're doing quite good. This is the number of people in an ICU, Oregon, compared to the number of ICU beds available. You read the stories in New York City. There was more people who needed ventilators, needed ICU beds than they had beds for. In Oregon, we have about 210 ICU beds, this line at the top, and we've only needed about 20, now 30 ICU beds. So we're well under our capacity. Everybody is able to get the best possible care they can in Oregon. So we still have unused capacity in our healthcare system. There has been an increase in COVID transmission, modest increase in the number of people who got sick, even people who are dying, but we still have a lot of healthcare capacity to respond to this increase in transmission and this increase in illness, such that people can get very good care. Next slide. So let's talk about some of the interventions we did and how effective they are. And I find this data really promising. What this does is it looks at how effective each intervention is at reducing transmission in a population. And this black line here is how effective our combined interventions need to be in order to contain the epidemic. If we can get our interventions more than 67% or 67% effective, the epidemic will shrink. Below that, the epidemic grows. So our goal is to keep our interventions, to maximize the interventions while still doing the things we enjoy, and just find that right balance such that we can keep the infection, we can keep the epidemic from growing. So first we started stay-at-home orders. Then we closed the schools. We went from 6% to 52% efficacy. Then the stay-at-home order, we were at 64%. When we had the stay-at-home order, that was enough to keep the epidemic level. And then the epidemic started to shrink as we had more school closures and we had our business reductions, and that epidemic, the interventions, combined effectiveness interventions went above 67%. This is where we saw the shrinking of the epidemic. Then we started to reopen things again, the phase 1 for many counties. This goes below 67%. We start to see the epidemic grow again. But here is the optimistic news. Look at this point here, the mask wearing indoors, the statewide order to recommend it and to ask everybody to wear a mask when they're indoors. We went from 50, 60% effective to 65% effective. It is possible with our current level of economic interaction, and if everybody wears masks, that mask alone, mask with the level of activity we have now, could be enough to push us up over that line and begin to start to shrink the epidemic. Masks are turning out to be really, really important. Please wear your mask. Next slide, please. So how are we doing relative to other states? Well, here's comparing Oregon to USA and Arizona. So in Oregon is the brown line here. And this is the number of daily infections diagnosed over time. We're the brown line. United States is the black line. And Arizona is the magenta line. We had a very different response in Arizona. We implemented our interventions early. We kept our interventions in place until the epidemic started to decrease and was under control. And then we slowly opened up the economy. And then when we saw infections start to increase, we started to do additional things like statewide mask wearing mandate. And this allowed us to keep the number of infections at a very low rate, much better than the USA and certainly better than Arizona, which never really implemented late their stay-at-home order and their closure of business and schools, implemented them late, and most importantly, release those interventions, stop those interventions while infections were still going up and before the epidemic and transmission was under control. And you can see what happens. If you open things up before the infection, the epidemic is under control, Arizona is now one of the hardest hit states in our country. Next slide. Here's deaths. Again, looking at Oregon here in the red line, the USA as a whole on the black line, and Arizona, a state that never implemented their interventions late and lifted them too early in the magenta line. And you can see that we've done very well because of early and sustained interventions, a calibrated intervention strategy over time, much, much better than the nation overall, and much, much better than Arizona. Next slide. There, thank you. I think that is our last slide. All right, we'll go back and turn the slides all down. So we were successful in Oregon. We have done a great job. We've done a great job by acting early, acting decisively, using the information to guide our actions and being able to calibrate the level of intervention we need in order to keep the keep things under control. I would characterize what we have now as we have an increase in transmission, and we have sadly an increase in disease, but this is a slow burn. This is not a forest fire like we've seen in Arizona and Texas and Florida. This is a slow, controlled burn. Can we continue like this? And then what will the future look like? Well, let's talk about the future. Let's talk about schools. Everyone's worried about schools. This is one of the most difficult decisions our state leaders have made because in-person instruction is one of the most important public health interventions we have. It's one of our highest priorities. It provides not only education, but provides social and emotional growth and support for our children. It provides nutritious meals and access to medical care. Schools are a really important part of our fabric, important part of our growth as individuals and community, an important part of our long-term economic well-being. But whether we can provide safe instruction in a school and in person in the school really depends on the virus and whether we can control the virus to a sufficient degree that we can make our schools safe. And as Dr. Fauci says, it will be the virus that makes this timeline rather than us. And it will be our interventions and how we respond and control this virus that will also influence that timeline. I also want to recognize that closing schools impacts different families in different ways. Some students don't have internet, and so moving online, many children are extremely disadvantaged. Many families struggle to find childcare for their children at home while they have to continue to work outside the home. And there's many students, their distance learning is really a challenge. And is suboptimal, is a big sacrifice compared to in-person learning. So how do we go forward? How do we move forward? Well, we first have to make sure that our schools are safe, and we have to make sure our communities are safe. And keeping transmission down in the schools is really important, not for just our students and our teachers, but for the entire community. Premature opening of the schools will cause another 2 to 4% increase in deaths of COVID. So having transmission in schools, opening up the schools before we can control transmission, will lead to more illness and more death in the community overall. There are some bright spots, though. There's new data that suggests that those children under 10 years old, they might get infected, but they don't, for some reason we don't fully understand, they don't seem to transmit COVID-19. They don't spread the virus like older children or adults. Children over 10, middle school and high school kids, well, they don't often get sick. They can get sick, but they don't often get sick, but they can transmit the virus. They can transmit the virus just like an adult. And so we must figure out a strategy to first control the transmission in the community, and then maybe think about the K through third grade a little bit differently than the fourth through high school. So the state has identified metrics with these challenges in mind to try to figure out, how do we open up? What is a safe way? What is our metrics to make sure that transmission is controlled in the school and we can open up schools safely? The state has said for us to move to an in-person model, which may include a hybrid model, that we have to have less than 10 cases per 100,000 people in the last 7 days. And that the percent of people positive, remember the graph I showed, percent of people positive, that has to be less than 5% over the preceding 7 days. And overall, we need to have less than 5% positive test rates in the state overall. How are we doing? Well, in Multnomah County, rather than 10 cases per 100,000, we have 54 cases per 100,000. We're still a long ways from getting from 54 down to 10. But we've been down to 10 before, close to 10. Been down to 10 before. I believe we can do it again. I think mass have a reasonable chance of getting us there. Where are we on the percent testing? We need to get to 5%. We're about 6.5% now. We're actually not that far away. So it is within reach. It is not here now, but it is in reach that we might be able to open up the schools. We will have to control the transmission of COVID-19 a whole lot better than we're doing now. How do we respond to K through third grade? Well, because K through third grade, children under 10 are less likely to transmit the virus. I think the guidelines suggest that we might be opening up the K through third grades a little bit earlier. So rather than a limit of 10 cases per 100,000 people, we could have maybe 30 cases per 100,000 people. And that there may be options to open up K through third a little earlier. There also are provisions that if you're in a rural school with with less than 100 people, we also, very small schools where there's a few people where we can monitor and control the transmission, we might be able to open up those schools a little bit earlier as well. So how long will we need to live like this? I know we're all tired. We all just want to go back to normal. Well, we are in our new normal, and our new normal is going to change. And I think our new normal could either get better or could get worse based upon what we do and how we respond. There's very promising news on vaccines. There are several vaccine trials that show early data. The vaccine front is very promising. There is a good reason to believe that there could be a vaccine that starts to deploy in January of 2021. But I think even if one of those vaccines are as safe and effective as we hope, and they are ready in this January, it's going to take time to implement those vaccines. And for those vaccines to implement the population to slow transmission in a major way, it's going to take us at least a year, possibly more, to deploy those vaccines. So I think that we will have our normal will look a lot like this for certainly the next year and possibly the next 2 years. It can look a lot better if we can control transmissions through wearing masks. But we will not be able to go back to where we used to be for, I think, at least 2 years. Let me end on a personal perspective. In 1986, I was a new medical student. I thought I wanted to be a neuroscientist and a neurosurgeon. And I thought the brain was the most fascinating thing on the planet at that time. But there was this new disease called HIV/AIDS. And I dropped out of my neuroscience program because I saw the impact of HIV/AIDS in the patients I saw and people in the community. And HIV/AIDS, I thought, and would believe for many years, would be the most important event of my lifetime. This occurred at a time when many people were looking the other way. And I think we responded really well. It took us a while, but we responded well to HIV/AIDS. And I thought I closed the chapter on the most important global health public event of my lifetime. But gosh, I was wrong. COVID-19 is so much more. There are a lot of similarities and a few differences, though, between HIV/AIDS in 1981 and COVID-19 now in 2019 and 2020. They both were a new disease that we had no history of. We had no understanding of, never seen before. And our first response was denial and fear, and we just hoped it would go away. We couldn't wish away HIV/AIDS. We could ignore our way out of HIV/AIDS. And we certainly can't wish or ignore our way out of COVID-19. In the early 80s, we had to face that fear, that stigma, and that denial. We had to face it head on, and we had to mobilize our leaders and our scientific community to act. To first and foremost, invest in the science to understand how these viruses impact the body. Then understand how the virus moves from person to person through a population. To understand first, how do we prevent this and how do we treat it and how do we control it, not only locally, but worldwide. It took us a long time to mobilize the resources, to invest in the science, to invest in the public health, to build the healthcare systems necessary for HIV/AIDS, to discover the treatments, to bring it under control. It took 2 decades. But in 2 decades, with HIV/AIDS, we now have over 80 million people living with HIV/AIDS and normal life expectancies. What we have achieved was not even imagined in the 80s, and that we can accomplish way more than we ever think possible. We invest in the science, we invest in the public health. And we build up health systems. We find new treatments, new vaccines, and we make sure everybody has access to them. We conquered HIV/AIDS in 2 decades. And sadly, we lost a lot of people along the way. But because everybody's impacted by COVID-19, because everybody understands the impact in different ways, that we are responding in a much faster way. It may seem slow, and certainly sometimes it seems slow to me. But I know it won't take us 2 decades to get ahead of COVID-19 because this is our problem. Every one of us is deeply invested in bringing this to an end. And when I hear the pots and pans ringing at 7 o'clock for our brave healthcare workers, our healthcare workers are really brave and they're important. I'm proud they're showing up and they're ready to care for the people who are sick. But I hear those pots and pans. I not only hear those pots and pans for our healthcare workers, I hear it for our leaders in the state, the Oregon Health Authority, the people who set the policies to help us respond early and effectively to control transmission, the people who are doing the contact tracing to identify new infections, the school districts who are trying to figure out how to respond, the university leaders to transition higher education online, to make sure we have safe places to teach our students. And the public health policy leaders and the Oregon Health Authority, they're doing the hard work to bend the curve such that we can mitigate the suffering caused by this virus just as much as possible, to keep this as a slow burn as possible, but also open up our economy. And those pots and pans are also for them. And I congratulate the great work we've done together and the great work you've done as individuals to give up things you enjoy, to go through this to wear your mask, to bend this curve, because those pots and pans are for you too. And thank you. We need your help, and we need your help every day. Wear your mask, invest in science, support public health, because you are public health. Thank you very much for being here. Thank you very much for being not only public health students, but public health practitioners and helping us all bend this curve.
Thank you so much, Dr. Bangsberg, not just for the lecture, but also connecting the coronavirus to previous pandemics. I really do appreciate that. And now we're actually going to move towards the Q&A. And we have already some questions from our viewers right now, and that I'd like to pass on to you. Sounds great?
Okay, yes, please.
All right. So the first question is, how do we know about asymptomatic spread if asymptomatic people are not tested? That's the first question.
Yeah. Well, there was one of the first studies was in a military ship which had a COVID-19 outbreak. A closed space, I forget the name of the ship, but a closed space where there's a lot of sailors and Navy people who became infected and became sick with COVID-19. There was a closed space. They tested everybody on the ship. And of all the people who were positive, only about half had symptoms. The other half had no idea. There's been several other studies looking at defined populations and transmission, and that has been replicated a few times. But it looks about half the people never develop any symptoms whatsoever. And the scary thing is that the people who don't have symptoms are just as infectious as the people with symptoms. So while you may not know you're infectious, you are infectious and just as likely to transmit.
Thank you. The next question is, are cloth masks okay? And are they effective, or do we need fancy masks or double masking, like with a shield and a ventilated mask?
Yeah, the cloth masks work really well. So there's like three types of things you hear people talk about. There's an N95 mask, which is the hospital grade mask. There is the cloth mask, and then there's these face shields. You see some people wearing clear face shields. Let me talk about first the N95 mask. That is the highest level of protection for really deep and intense concentrated exposure to COVID-19 that you would see during a medical procedure. So if you are helping examine a patient into putting a breathing tube in them where they're coughing and they're coughing in your face and there's a high concentration of virus, you need that level of protection to have a high degree of certainty that you won't be infected or exposed to COVID-19. So those are really important for the healthcare settings. But for less intense exposure than a medical procedure, the cloth masks work quite well. The cloth masks work in two ways. They work mostly by preventing the person from becoming infected to transmit it to others. So it keeps the infectious person from being a source of transmission. That's the first and most important, but it also has a level of protection for yourself. So if you're in a space with someone who is also infected, the risk of transmission is lowest if you both wear masks. So you can protect yourselves and you can protect others if you're both wearing a cloth mask, and to a very high degree. There was a study in South Korea that looked at two people who worked in a hair salon. And they had worked right next to each other, and they both had COVID-19 for about 3 weeks. They didn't know it, but they figured out they had COVID-19 for 3 weeks. They each saw about 150 clients, and they went and they reached out to all the clients and tested them for COVID-19. And because those two hairstylists wore their masks all the time and washed their hands and did all the things we ask people to do, not a single person was infected with COVID-19. So hand washing with masks, and that was in an indoor hair salon inside, can be extremely, extremely effective. Now let me touch on the face shields. The face shields, they were a good idea, especially when we thought that this was more like influenza and transmitted through droplets, through like when you cough and or sneeze, there's a spray. The face shields are very good at preventing that transmission. Or if someone were to cough or sneeze in your face, they're a very good source of protection. But they're less effective for an aerosol. And it looks, as we learn more about COVID-19, there are really small particles that become aerosolized and basically float in the air. They're like almost like a gas. And so the face shield, the clear face shields, are not as effective as a mask, as a cloth mask, at both protecting yourself or protecting others. So grab your cloth mask, take it everywhere you go.
I got mine right here.
Yeah.
For the next question, how do I convince my friends of the accuracy of the infection data and that it's not just miscategorized or over-reported?
Well, I think it's by looking at multiple sources. Yes, we are doing more testing. The test itself is pretty good. I mean, the virus test is a good test. The antibody test that's more complicated, but the virus test is a very good test. We are doing more testing. As we do more testing, we find more infection. But we need to look at other things too. And as I've mentioned, it's the percent positives of all the tests we're doing. If we do more tests and the infections don't go up, the percent positives is going to go down. We're not going to see people go into the hospital. We're not going to see deaths. Another marker or thing to look at that I didn't mention is the number of people when there's contact tracing. So for every person who's reported to Oregon Health Authority calls them up and says, okay, who do you live with? Who do you interact with? And contacts those people in concentric circles to see who might have been exposed and who's infected. And the number of people who have received COVID from a known source is also an important metric, because if there's micro pockets, small pockets of transmission, should be if it's from a family member or a workmate, you should be able to detect it. And that's very different than community level transmission. If it's just everywhere we go, then it's much more difficult to find a source. And so there's percentage of infections that can be identified to a source. When they start to go up, and they're starting to go up a little bit in Oregon, that's a concerning sign. So that's a sign that there's more community spread of transmission, or community transmission of COVID-19. Very good question, thank you.
The next question that we have, because fall is coming pretty soon for us, what are the predictions for ICU capacity when it becomes influenza season? Yeah. Well, because we acted early and decisively in Oregon, I work at OHSU-PSU School of Public Health. A lot of my colleagues work in the hospital at OHSU. People were really scared in March about the ICUs being overwhelmed. There was decisions like, how do we get more, how do we create more beds, get more ventilators? Some of the same discussions that were happening in New York. And because we acted early and decisively, we bent the curve and we stayed about 10% of capacity. And that's an enormous, enormous success. Such that every patient who went to the hospital got really great care. And that's not just OHSU, it's through every hospital in Oregon. When influenza happens in the fall, we need more ICU beds. We'll need beds for both influenza and for COVID. And we've never seen that before. And the question is very insightful, that the real test of this system will be in the fall. But I think we've done well enough that we have plenty of reserve ICU capacity that we could handle all the influenza. We could treat all the patients with influenza, and we still have more room for a little bit for more COVID. So we're in good shape, but we shouldn't take this casually. We should do everything we can to keep transmission under control. So we don't get have the experience that New York had in March and Florida and Texas are having now. Yeah. Thank you. The next question is it true that medical experts told people that they didn't need to wear masks early on so that Americans wouldn't hoard the N95 masks like they did with toilet paper?
Yeah, well, so that's a good question. It's let me answer that in two pieces. This is a new virus that we've never seen on the planet before. And we had to invest in the science, and the investment in science and understanding this virus has been faster than anything I've ever seen. But it takes time to understand how this virus works and how it's transmitted. It's taken months to figure that out. And in the absence of that scientific knowledge, which we had to collect, which was for this virus, we basically used analogies for similar viruses like influenza. And for influenza, transmitting influenza, wearing masks is not as important. And so the scientists, because of analogies with influenza, definitely underestimated the impact of the mask. As we invested in science, we understand how this is transmitted, and it's transmitted in a different way, more aerosol and less droplets than influenza. Influenza, the most important thing is to wash your hands and avoid surfaces. For this virus, it's not like influenza. The most important thing to do is to avoid contagious air that someone else has in the same space that someone else has with COVID-19. We didn't get that. We understand that now. So yes, there was a underappreciation of the importance of the efficacy of masks because this is a different virus and it's different than influenza. And we made the best assumptions we had, but they weren't right. And now we know better. There was also extreme pressure on N95 masks, and we do know that you need an N95 mask to keep our healthcare workers safe. That we were not only worried about enough ICU beds and enough ventilators, we were worried about having enough doctors and nurses and respiratory therapists because they were getting sick, and once they get sick, they have to come out of the hospital. And we were concerned for both the health and welfare of the healthcare workers, for their own well-being, but also if we don't have enough doctors, nurses, and respiratory therapists, we can't care for all the people coming to the hospital. So yes, there was a message, and I think a very appropriate message, that saved the N95 masks for the healthcare workers, so we can keep our healthcare workers healthy, so our healthcare workers can care for our people.
I actually have one question I want to share personally, and then I'll go back to the questions from our viewers. At the beginning of your presentation, you had mentioned and you had acknowledged like the connection between systemic racism as well as the impacts of COVID-19 on BIPOC communities, so Black, Indigenous, and people of color. I was just wondering, in terms of the protests that have resulted due to the civil unrest of the murders of George Floyd, Ahmaud Arbery, etc., and Black Lives Matter movement, there was like this misconception that there would be an uptick in terms of cases because there were people congregating and stuff like that. And I was just wondering, because from what I know, the data hasn't shown that. I was wondering what you can attribute to the fact that the cases didn't uptick as much as people predicted.
Yeah, I think as we understand transmission of this virus more, we appreciate there's two really good things. One is being outdoors, and the other is wearing a mask. And I think seeing the protest myself, most people were wearing a mask, and most people were outdoors. And those are two really important protective factors. And so when people are together, and people, they were probably a little closer than 6 feet on occasion, but nonetheless, being outdoors and wearing a mask is so important. And that was enough protection, even in a large crowd, that we haven't been able to detect much in the way of transmission.
Thank you. So the next question, so this is kind of a comment. It says, I've heard the opposite recently. I've heard that some scientists are saying that small children may actually be more contagious carriers than adults, even if they are asymptomatic. I can't say that word, asymptomatic. Response, that's the question.
I haven't seen that, but if you're one of your viewers has information, has read something, there's so much scientific data coming out that's really hard to keep up with it. And so if that viewer has a paper to read, I would love to see it.
Thank you. The next question is, there's a college cluster in Eugene. In Lane County, a regular COVID infection transmits to 4 other people, but a college cluster, one transmitted is 28. Is it safe to have any in-person classes?
Yeah. Well, I can, as a dean of school of public health, we spent a fair amount of time thinking about this, both at OHSU and PSU. We were a school at both universities. And this was a very difficult decision, just like what to do with K through 12s. It's a little bit easier to make the decision, I think, for university students because they're older, less reliant on sort of emotional maturation, the social interaction as a young person. And we adjusted to fully remote online learning in a matter of a week. And that transition was pretty smooth. And actually, a lot of our students really like it. And they have more flexibility in an online format, especially our students who are also working. And I think the online format for a college student can be quite effective, and some students actually prefer it. We at OHSU and PSU, we thought about this, we debated this. We are very concerned about the safety of our staff and our faculty. Because we know that if you're in a closed space, and if not everyone, being in a closed space increases your risk. And that could be mitigated by wearing a mask, but not fully mitigated. And so we were really concerned about exposing our faculty and our staff, some who may have pre-existing health conditions. We don't really want to, ask people to share their private health information, but also we knew that people they might be at low risk for getting sick with COVID-19. They may live with someone who is a higher risk, live with a parent or live with a relative. So in the end, we decided we would do remote learning. And we thought it was the best decision for our students, the best decisions for our staff, and best decisions for our faculty. We have very limited online learning, very limited in-person learning for those faculty who really, really want to teach in person, because some faculty really do. And they can provide a really safe, controlled environment that we will have some in-person teaching at PSU, but be very limited. And I think we will use the data to change our policies, and hopefully we'll provide more in-person instruction, as we get better control of transmission. I would be concerned about my students, and my children who are college age, going to a residential university and being exposed to a large group of people inside who may be inconsistent with wearing masks and other protective health behaviors.
This is not a question from a viewer, but I guess from my personal curiosity, you know how some colleges are considering still hosting dorm style type of housing? How do you feel the response in Oregon, if you know what that response is by college, or is it really dependent on a state by state cases?
I think it's a college by college basis. And we at Portland State University, we have kept our residency halls open for a limited number of students. We have a number of students from other nations who just don't have the resources to travel back home. And we think that we can provide safe housing for a small number of students in a very controlled environment. And we think that's the right thing to do. We have encouraged we've certainly encouraged remote learning, virtually all of our instructions by remote. And we've also encouraged people to find, best they can, a safe place to live where they can have a little interaction. I think the large dormitories and managing that in COVID-19 is going to be really challenging.
Yeah. I just personally, I just remember when I was at PSU, remember all the types of dorms that, different amount of social distancing would not be as effective compared to when I was, visiting there. So, and studying there. So it's just, I think it's harder for a young college age population to adhere to social distancing. But please, all the young people here, college age people, please, the more you can, if you are able to wear your mask, you're able to keep a physical distance, not social distance, but a physical distance. You can still be very socially close, but keep a physical distance. You're saving lives, and you're saving lives. You'll help us move our economy so people can keep food insecurity, housing insecurity, and all the economic, mitigate all the economic consequences of our intervention. So it's really, really important. The next question is someone saying, I've heard reports of folks who recovered from COVID-19 and got it again a few months later. suggesting that immunity doesn't last very long. So what does this mean for the development of an effective vaccine?
Yeah, well, let me break that down because it might be confusing. There might be different data sources there. It's clear that people can become infected, they develop an antibody response, and those antibody responses can fade over time. So immunity can fade in terms of what you detect in the blood. That doesn't mean a vaccine won't work. A vaccine, once you have been exposed, your immune system seeing COVID-19, once it sees it, the second time it sees it, it will respond quicker, more effectively, and almost certainly the next infection will be more mild if it occurs at all. So the lack of immune response in a laboratory test doesn't confer the degree of protection later on, and it doesn't predict that a vaccine will be ineffective. So just go back and ask, when you start to look at that data, is it antibody response or is it a viral response? And yes, the antibody responses fade, but that just because they fade in the laboratory tests, that memory, that immunologic memory is still there. Your immune system is ready to respond quickly and more effectively that second time. And that's what the vaccine will do. And I'm still very optimistic about the vaccines. Whether people can get an infection twice in a row, I've been looking for that data. I haven't seen it. I won't say it's impossible because there haven't been the studies, but it's if it happens, it's not been documented very often. So I think it's a rare event. But again, that's something I haven't seen, and I'll encourage your reader to put that reference in a link and be glad to soak up that information.
All right. Next one. This is kind of like a gauntlet. You're just one after another. Mm-hmm. So the next question is, what can or should the Oregon Public Health System, or Oregon Public Health, do about systemic racism?
I think Oregon Health Authority and Oregon Public Health System is taking this very seriously. In their overarching theme going forward, even before COVID, was to address structural racism as the #1 public health priority in Oregon. So I think, and we are, every public health issue we address on the Public Health Advisory Board, which I'm a member, and also on the Oregon Health Policy Board, which I chair, is seen with a foundation, an anti-racism foundation. I think it's not only us in the School of Public Health, it is the entire public health system and Oregon Health Authority that recognizes racism as one of the most important, if not the most important public health issue in Oregon and in our nation.
The next question is, whatever happened to the random statewide testing initiative that was planned?
We have launched that. We have we're following about 9,000 people looking for COVID-19 with voluntary testing and symptom monitoring. We haven't seen the recruitment that we had hoped, and we haven't yet to detect the sources of infection that we thought we might be able to. We think that maybe it was a strong strategy that was very optimistic before we knew a lot about COVID-19. We think that we're now thinking about other strategies that may be more adaptive.
Okay. This next one I'm actually very curious about too is, can you talk about post-COVID syndrome? Post-COVID
syndrome. Well, I think a lot of the damage that's caused by the disease COVID-19 is not by the virus, but the immune response. And there's in some people, your immune system has an exaggerated response. That immune response causes more damage than the actual virus. And that immune response can cause vascular inflammation, which can cause COVID toes, is like a small hemorrhage in your toes. You get these blue or purple toes. You can have inflammatory response in your gut. You can have inflammatory response in your brain. So there's all these different inflammatory responses that one can have that can last weeks long after the virus is gone. Doesn't happen in a lot of people, but it certainly happens in some and be quite debilitating and can impact several different organ systems.
Okay. The next one is, how many layers does the cloth mask have to be for it to be effective?
I don't have a good answer for that one. I think, everyone I've had had 2 layers, but I haven't looked at the science as to whether 2 layers is better than 3 layers or better than 4 layers. So I'll have to get back to you on that one. But any cloth mask is better than no cloth mask.
True. All right. The next one is there any data for what someone getting the flu along with COVID would experience?
Not that I'm aware of. I think we will learn more about that in the fall when flu season starts. And we will, I think COVID-19 has been very challenging in the spring and the summer by itself. When we get the flu, I think it's become more challenging because, to differentiate, who has flu, who has COVID-19 will be really tough. I think it makes it all the more important for people to get their flu vaccine this fall, because we need to keep all the capacity in the healthcare system we can. We need to keep people as healthy as we possibly can. So even before we have our COVID-19 vaccine, please go get your flu vaccine. We need it now. Now is the most important year to get a flu vaccine if there ever was one.
The next question is there any reason not to use the readily available KN95 masks rather than the homemade cloth masks?
The only reason would be shortages of N95 masks. I think that because we've controlled COVID-19 well in Oregon and there's plenty of clinical capacity, I think that the shortages of N90, we're probably over the shortage of N95 masks that we had before. So I think if you have an N95 mask, I don't think it's wrong to use it. But I think a cloth mask is perfectly effective.
I just realized they probably mistyped, and so I said K, and I was like, oh, that seems weird, but they meant the N95 one. For the next question is, what is the estimated percent of Oregon's population will need vaccination to help reduce transmissions?
I've heard 70% is really where you sort of the common estimate for herd immunity. The more is better. If we have a safe and effective vaccine, and I'm optimistic we will, that every person you vaccinate is one less potential COVID case, one less person with COVID. And that means two things. If you vaccinate somebody and you prevent a COVID infection, you prevent an illness in that person, which is good. And you also prevent a source of transmission to others. So everyone is important. And you begin to see the level of protection having population effect in terms of protecting the majority of people who are vaccinated and unvaccinated, about 70%. So that would be, we'd like to get to as close to 100 as possible, but 70% is really where you sort of see the curve bend in terms of protecting people who are not vaccinated.
The next question is, how much would current levels of national PPE production have to increase to be able to return to pre-COVID hospital hygiene protocols?
I'm gonna have to defer on that question.
Yeah. Before I go on to the next viewer question, I actually have a different question. You had mentioned as well that this is disproportionately affecting the Black and Brown communities. I was just wondering, are there particular efforts or strategies that the Oregon public health system is trying to push to better serve those communities?
Yeah, I think one of the things that Oregon Health Authority is doing is expand testing to make sure that testing is available for any person, a Black, Brown, or Native American community. That testing is really important in terms of limiting transmission. I think we're always paying attention and trying to do what we can to mitigate the social and economic consequences of our interventions, because I think Black and Brown communities are more likely to get infected because of the types of jobs they have. Once they become infected, it's often less likely to receive optimal health care. And because of other stressors, including chronic, systematic structural racism and other comorbid conditions, are more likely to get ill. So I think addressing the inequities has to be at every level from the social, structural, economic, in terms of to access to healthcare, to addressing sort of consequences of COVID. So it's at every layer.
Thank you. So back to the viewer questions. How will the different virus mutations or variants impact the efficiency of the vaccine?
We don't know yet. influenza is a very good example. And again, sometimes we get in trouble by making analogies to influenza for lack of better data, because this is not influenza. But the reason that we have to take a different influenza vaccine every year is because influenza mutates, and the strain of influenza we have in 2019 is different than the strain we have in 2020. And so the vaccine has to be adapted for each year to match each strain. COVID-19 definitely mutates. It was changing over time. Whether it's mutating in a way that will require a new vaccine, adapting the vaccine each year, I think is too soon to tell.
The next one is, latest study from Germany says that recovered patients have permanent heart damage. Mm-hmm. Wouldn't this knowledge help folks wear masks?
I think people with COVID-19 affects a lot more than the lungs. Gastrointestinal system, the heart, the brain, the kidneys. It can affect a whole range of systems, important health, biologic systems outside the lungs. And yes, there's so many reasons to wear a mask, to protect yourself and to protect others.
Yeah, thank you. The next one is, what have been the successful precautions within medical clinics that are seeing patients in person or are planning to reopen to direct patient care in order to reduce the transmission between all of the people inside the building?
Yeah. I think, there's been a real movement towards telemedicine, which I think has been an important innovation in medicine in response to COVID-19, that a lot of healthcare can be delivered over the computer and the internet. And I think that's one way that a system has responded. And I think that's a nice innovation. I went to the dentist the other day at OHSU, and I was really impressed with the level of controls they had. When they wouldn't let you walk in, you had to knock on the door, and then they check your name. Make sure you have a mask, and then you wash your hands with hand sanitizer, and then check your name. They have you sit in a separate space before you're ever seen. So the level of control, the level of protection in the healthcare facility is much, much better than anything else you're going to do in terms of, a healthcare facility is much safer than going to a restaurant or any other indoor space where you might be with another person.
If I could quickly share, one of my best friend, actually, he's a frontline worker, and that's one of the things is he tells me the stories of like how they have to check their temperature, and they have to do all of these steps that I think in the past we would take for granted, and now that you got to make sure that everyone has masks. He has multiple layers. It's just, yeah, I would agree to what you just shared, that the layer, it's like when you would go to a concert, the flashbacks, throwbacks, but when you would go to a concert and there's the security detail and everything, but now it's just so it's even more secure than that, so that, you can't just get into a concert. Now it's you got to show this, you got to show that, you got to do all this. So yeah, I just wanted to share that as well.
Yeah, I think the healthcare facilities are probably the safest indoor space there is.
Yeah, definitely. Going back to the questions, how are you doing, by the way, Dr. Bangsberg?
I'm good. Yeah, I'm good. Yeah. Yeah.
Okay, you've been going through these like a champ, so I'm really proud of you. So, okay, so the next question is, some people are saying that it's not only a respiratory disease, but also a vascular disease. Mm-hmm. So the virus gets into your blood. Do you agree?
Yes. Yeah. It causes inflammation in many parts. That's why I mentioned it affects the heart, it affects the lungs, it affects the gastrointestinal system. It does that through the vascular system.
All right. That cleared up some stuff for some people. So the next question is, how would you advise public health authorities or healthcare organizations to allocate vaccines?
Well, I think there's a lot of national discussion about how to prioritize vaccines. Clearly, I think there's agreement as to healthcare workers should be first in line for providing vaccines, because they're both high risk in terms of exposure and caring for patients. Also a really important resource to maintain to care for other people sick with COVID. So I think there's agreement on that. I think there's a lot of agreement on giving vaccines early to people with comorbid conditions, other health illnesses, and elderly. I think there's a really, really strong argument, and I think in my mind, effective argument to making a priority for Black and Brown people and Indigenous people. Also for essential workers, people who are working in essential services such as grocery stores and providing services to us all. So I don't know. There's not consensus on all those principles, but those are what people are thinking about, and I think those are all really important things to consider.
The next one is, how or why is anybody brave enough to volunteer for a vaccine effectiveness trial, as I assume they'll be purposely exposed to COVID-19?
Well, they won't be. They'll expose to proteins that are related to COVID-19. They won't be exposed to live virus. So we're no longer using live virus vaccines or attenuated virus vaccines. We're using synthetic proteins that are created from the genetic code of COVID-19. So they're the same proteins, but they're not made from a live virus. So there's no risk of getting COVID-19 from a vaccine. There's no actual replicable live virus in the vaccine.
Okay. The next question, and I didn't know that's really cool to hear. The next question is, does the coronavirus impact those who are already immunocompromised, those with, for example, type 1 diabetes, thyroid, Crohn's disease, or others?
Yeah, that's going to be one of the most important scientific questions to ask in terms of developing an effective COVID-19 vaccine. Vaccines traditionally work in people with really good immune systems. And people with immune systems that may be compromised, they may have a partial vaccine response. And tragically, those are the people who need a COVID vaccine the most, effective COVID vaccine. So there's quite a reasonable possibility that we get several generations of COVID vaccines. And, the first generation COVID vaccine may hopefully works in most of the people, but might not work in everyone. And then we'll need to fine-tune that vaccine to make sure that we're able to get a response in people who are older or other have a compromised immune system.
Next question is, how is Oregon doing with respect to time for getting test results?
We're doing okay. It's starting to slow down a bit because Oregon Health Authority has had to scale up train new workforce for contact tracing to make testing available, to work on the supply chain in response to the amount of the epidemic. And we have more COVID-19 than we did 2 months ago. So it had to scale that up. I think they've done a good job scaling up in terms of people for contact tracing, but there's been a national strain in the availability of tests. And that's not so much because of what Oregon's doing, it's just what we're seeing in the nation. We thought we saw the worst of this in March when New York and New England was having their challenges. But we're seeing many more COVID-19 infections now than we were seeing in March. And they're all occurring in Florida and Texas and Arizona and Georgia and Alabama. And that demand that showed you the curve for Arizona is those curves that are really driving the demand for testing. And we as a nation are having a hard time keeping up with that. And so that slowed down the turnaround time for tests here in Oregon as well. It's not so much what we've done or not done as in Oregon, but it's what's happening in the rest of the country and the need to scale up testing in an exponential manner because of the exponential growth of COVID-19 in the rest of the country. In other parts of the country.
I just want to do a time check for our viewers. Right now it's 8:10. We have about another 15 minutes for the Q&A. So please, if you have particular questions that you want to ask Dr. Bangsberg, please do so in the feed. So the next question, Doctor, how does Oregon's high revenue dependence on people playing lottery slot machines in bars impact Oregon's ability to deal with a pandemic?
That's out of my area of expertise.
Okay.
But I would love to learn.
Good question, though. But
good question. I'll look that one up.
Yeah. All right. The next one is, can you talk about the Key to Oregon? This viewer said they recently received a letter inviting them to join.
Yeah. So Key to Oregon is a strategy where we will offer people free daily symptom monitoring and free COVID testing for a random sample of households throughout the state. We will also offer COVID-19 testing for a number of asymptomatic people. The goal of this is to detect early infection before they become early pockets of infection before they become a second wave. So it's a strategy to monitor regionally how we are doing, how to respond to either increases or decreases in COVID-19 in order to give us scientific data to guide for the state to have scientific guided and guided policies.
Thank you. The next question, I'm actually going to combine two because they are related. Is asthma and or sleep apnea considered a serious or an underlying condition?
Pretty sure asthma is. I would suspect sleep apnea is as well. Though I haven't read anything in particular about sleep apnea, I would, I'm a MD physician, but I haven't practiced in a few years. And so if that person has sleep apnea, I would encourage that person to reach out to their primary care provider. But I would be concerned that would increase their risk.
Okay, thank you. The next question is, will there soon be a point of care test that is easy and effective?
Mm-hmm. Yes. None that I know of that are FDA approved, but several in development that will look at COVID-19 proteins on a filter paper. And basically you do a finger prick and we'll be able to determine whether you have COVID-19 on the spot as you would with a home pregnancy test. Having a simple available test that has a result within minutes after taking the test obviously would be so important and so helpful in terms of scaling up testing. So yes, under development, not yet widely available, and I don't think it's yet FDA approved. Okay.
Next one is, this is kind of a long question, so hopefully I'll set it up. If you need me to repeat it, let me know. Historically, isn't it the case that to prove the efficacy of the vaccine, one of the last steps, you would first give the vaccine to a small number of people, and then after a period of time, then give them the COVID-19 virus, and then make sure their immune system kills the live virus? Is this no longer the case?
Well, I don't think we do vaccine studies where we purposely expose someone to the infection. I think, or in early vaccine development in terms of smallpox, I think that was the case. But we wouldn't, in a vaccine trial, purposely inoculate somebody with COVID-19 in order to see if they have a vaccine response. And sadly, nature is doing that for us, and plenty of people are exposed. And so we don't have to do that. Nature is doing that for us.
Okay. Next one is, could you comment on the development of therapeutic agents like remdesivir and other drugs and how we are improving treatments?
Yeah. So I'm not, since I'm no longer practicing, not up on the latest science, but remdesivir, as well as some anti-inflammatory medications have been effective at controlling disease related to COVID-19. And many more new therapies are under development. We certainly saw this with HIV. It was the advent of safe and effective therapy that changed the course of the epidemic. And we had some existing drugs that seem to be effective, and new drugs are in development. So I'm also not only optimistic on the vaccine front, but I'm also optimistic on the therapeutic front.
Next one is, why has asthma not been that big a factor in COVID?
I have to pass on that one. I have to look that one up.
Okay.
Thank you.
Yeah. The next question is it viable to expect our healthcare workers to keep working as hard as they are now for 2 more years?
Mm-hmm. Well, I think our healthcare workers in Oregon have managed this quite well because the public health response has been so effective. We have not stressed the healthcare system in Oregon with COVID-19, despite our worst fears. New York had a very different experience. Florida, Texas are having a very different experience. And yes, I have many of my clinical friends who are still practicing in New York, and to hear their stories and the stresses they were under, both in terms of being concerned about their own health, but also seeing people suffer and pass in such a difficult circumstance when they don't have, can't be with their families. The emotional stress for those health workers were indescribable, or just simply profound. And there's so many important reasons for us to make sure we're using public health science to control transmission, especially now the science is so clear. We know how to control this. We can control this. We just have to do it. We should never be in that situation where the healthcare system is overwhelmed like that. We didn't understand that when New York was overwhelmed, but we do understand it now. And we know what needs to be done. It has been proven over and over again, state by state. Again, Oregon did a great job. Oregon never stressed the healthcare system, but gosh, we need to be able to get control transmission in every single state such that we can develop control as a nation. I'd like to reflect on what Europe did. Europe was hit really hard, especially Italy and, particularly France. The Italian healthcare system was overwhelmed. They barely kept up with the number of patients in the hospitals and needing ICU care. But because Europe responded, a large geographic region responded in a scientifically driven way, they were able to get transmission under control. They were very cautious about opening up their economy. They waited until it was well under control. And when they did, they opened things up, and there's still some transmission, but there are pockets of transmission, and things aren't entirely normal. But gosh, they're a whole lot more normal than they are here in the US. And it was decisive early action, sustained action until it was well under control, and then slow and cautious opening up led to a much more robust response and recovery than what we're seeing here in the States.
The next question is, are universities helping with testing?
I think there's some really exciting stuff at U of O and OSU in terms of testing. I'm not directly involved with it, but I have friends and colleagues there, and I think that they have some new, really promising ideas to expand testing capacity in the state. So yes.
Awesome. That's good to hear. The next question is a federal coordinated response to a pandemic essential because states can't deficit spend?
Well, I think I'm not an economist, but yes, deficit spending certainly limits the amount of response you can only do what you can afford. So that is a constraint. I think the bigger constraint is a coordinated federal response, because if each state does it differently, each state, like New York, establishes control, and then it pops up someplace else. For instance, California did a great job. The first case was in Washington, as you know. The first case was in Washington. Washington, California, and Oregon all had a very early and effective response. New York was a little slower to respond, but they responded strongly, and their response was in place until they were on the other side of the curve. They did a great job. Now California is seeing more infections. They're now in a second wave because of spillover from Arizona. And I would characterize this as whack-a-mole, and that we're controlling, if we control it state by state at different times, then what pops up, while we have it under control in Oregon today, what pops up in Idaho or Arizona or California could impact us tomorrow. And then Arizona may get under control. It could go someplace else and then go back to Arizona and then wind up back in New York again. So this whack-a-mole strategy, I don't think, is the best public health strategy.
Yeah. All right, everyone, we have another time check. We have about 5 minutes. So at this point, we might not get through all the questions, but just FYI. So doctor, the next question is, I hope I'm not butchering this. Does hydroxychloroquine and zinc prevent COVID-19 replication? And can inhaling nebulized steroids prevent lung inflammation if given early?
I won't comment on the biologic impact of hydroxychloroquine and zinc, but hydroxychloroquine does not work in clinical trials. zinc, I haven't seen the data on zinc. And I'm not up enough on inhaled anti-inflammatories and steroids to comment on if they're effective or not.
The next question is, with SARS-1, the trial vaccines caused a harmful response at Th2 in the lungs of persons who were later exposed to the virus. Will the COVID-19 vaccine safety tests be adequate to discover whether a similar effect occurs?
Yeah. It is true that some vaccines cause a paradoxical immune response, and that immune response can cause disease. I think that people are very attuned to that possibility. That's the biggest risk of a COVID-19 vaccine, and we'll look at that carefully.
Okay, thank you. All right, I think we have like maybe 2 more questions, maybe 3. So the next question is, an organization in England was training dogs to sniff out people with COVID-19 infections and claimed success. Have you heard anything about progress in that area?
No, I haven't, but it sounds really innovative.
Yeah.
And I would like to learn more about that. And it would like to be very provocative to think about how that could be deployed as a public health strategy.
Yeah.
The one thing has happened is that the animal shelters have really COVID-19. One of the best things that happened with the COVID-19 epidemic is people love their pets and have adopted a lot of stray animals and provided them home because now they're all home. There's nothing like having a good pet to keep you company for that emotional and social support. So here for the pets and the support they give us.
Yeah, awesome. All right, the second to last question. This will be the second to last one.
Okay.
Smokers were detected to be less impacted by COVID in France. Are you familiar with any studies on how the nicotine chemical prevents COVID-19 from entering a cell?
All I have to say, I'm really impressed with your viewership.
Yeah,
smart group.
Scientists.
We should be asking them for the trivia questions next time.
I know.
I don't know that one either. I have to pass on that one. But oh my gosh, send me a note, and we're gonna give you a lectureship in the OHSU-PSU school. There's a really smart bunch here. Yeah.
Yes, there are. All right. The last question is: since doctors have been treating COVID for almost 6 months now, have they learned any new ways to treat the virus?
Yeah, I think we know the remdesivir works. There's anti-inflammatories that work. The mortality of COVID-19 for people in the hospital has gone down. So they're just like I said, I'm optimistic on the vaccine front. The therapeutic front looks very promising. There's already important advancements that have been made that if you were to become seriously ill, you're more likely to survive COVID-19 than in the first months of the epidemic. And obviously, that science, we need to invest in that science and continue those advancements.
All right. And I have one final question for you, not tied to COVID. Well, kind of a little bit. But what are you doing right now in your free time to keep yourself sane during COVID?
Well, as a dean of a school of public health, I am blessed with meaningful and challenging work, and there's never been more meaningful, more challenging work than right now. And so I take a great joy in being able to engage in these issues. I take even greater joy in talking with my students. Every day I usually reserve a half hour for coffee with a student because it's our students in public health that will take on not only this challenge, but the future challenges to come. And to see the energy, the enthusiasm, their interest, their desire to make a difference in the world, positive difference in the world, is just a real joy. And so that's how I get my fuel for the rest of the day, is through the energy and excitement of my students and helping them with finding the classes and the faculty and the tools they need to make a difference. And the way I finish up my day is with a bike ride between the Telecom and the Selwood Bridge every day on each side of Willamette. That's a nice way to finish up.
Oh, so you might be passing through OMSI and we're not even noticing.
Oh yeah, I'm by there every day. Yeah.
Awesome. Well, next time you should stop by and say hello. So
okay, I'd love to.
All right.
And let me just also say, put in a plug for OMSI. I want to thank everybody for attending. OMSI is just the most amazing institution. I started my scientific career as a 6th grader in the OMSI Student Research Lab. And it was my mentors at OMSI said, yeah, you have promise, and science is a great way to make a difference in the world, and introduced me to that opportunity. And thank you to OMSI. You totally changed my life in a really positive way. And I am so grateful for OMSI and all the lives that you're changing today.
Thank you, Doctor. And also thank you for your time. We really appreciate it. All right, everyone. So we are out of time. It is 8:25. I hope that you enjoyed tonight's event. If you would like to watch this video again or share it with your friends, check out the video section on OMSI's Facebook page or our YouTube channel. And don't forget to follow us on Facebook, Instagram, and Twitter for updates on future events and inspiring content from OMSI. Personally, my favorite ones are Ask an Educator. So make sure that you check us out on our social media. And I know I mentioned it at the beginning, but please consider supporting Science Pub and making a donation via the Facebook donate button, or you can also visit omsi.edu/donate. You can also join us in 2 weeks on Tuesday, August 18th, so take out your calendars, for a lecture by neuroscientist Dr. Luca Mazzucato from the University of Oregon. He will teach us how your brain processes time, how a split-second decision can save your life, and how the concept of time may emerge by learning associations between consecutive events. Once again, thanks to our partner Celestream, for helping make tonight's event possible. And as always, you can get more information on our website at omsi.edu. Thank you, everyone, and thank you, Dr. Bangsberg, and everyone have a good night.
Okay.